There you go. Okay. So yeah, we're gonna spend some time together today. We're gonna talk about transfusions in the afternoon. We're gonna talk a little bit about how to run a resuscitation later on this morning. And this morning we're gonna talk ECPR. And I'm so thankful for Amal. I mean, I get to speak with Amal at a number of different things, but having him give that talk is so great for me to kind of jump into where we're going and maybe what the future of resuscitation looks like. So I actually have a favor of you for this lecture. We're going to talk ECPR. We're going to talk about how we do it and the nuts and bolts and a lot of the specifics of it. But I want you to kind of think about this in a broader sense. I want you to ask the question of where are we headed? And by we, I don't mean emergency physicians. I don't mean intensivists. I mean as resuscitationists. Where are we going in the field? What are the skills that we need to do to be able to develop so that we can do the next level of resuscitation, the future of resuscitation? And the reason why this is important to me is that because I got catapulted into this ECPR, mechanical circulatory devices, and a lot of these advanced techniques, I actually have been able to get involved with a lot of the innovators in the field. People who are doing cool new devices, new ideas. And one of the limiting factors that I think we under-recognize is that they are looking to us and asking the question of whether we would be willing to do that. If we as resuscitationists would be willing to kind of go the next step, to learn the intervention, to learn the technique, to be able to deploy some of these really cool ideas. And so for this, we're going to talk about ECMO, but ECMO is really kind of just a basic. It's really quite basic. It's a pump, it's some cannulas, it's an oxygenator. The future is so much bigger than that, all right? All right, so that's the question I want you to think about. As you said, I do ED ECMO. On the site, for all of my lectures today, I put the bibliographies for everything. So if you want to jot that down, if there's ever an article that you see, it's like, I just want to see what he was referencing, you can go there and you can pull through all the 3 lectures that I did today. All right, so let's get started. My story with ECMO started 8 years ago, and it started with this guy right here. 59-year-old guy, out of hospital cardiac arrest, pre-hospital EKG showed a STEMI. He got brought to us. We did all of the usual things. We did the dual sequential defibrillation. We did multiple different shocks. We did everything we could from a typical resuscitation standpoint to try and get this guy out of his cardiac arrest. It failed. But instead of stopping that day, we actually went a bit further, and we ended up putting him on ECMO. We did it in less than glamorous fashion, let's just say that. We screwed this up almost every way possible, but somehow, after 69 minutes of arrest time, we were able to get him on the pump. And you talk about calling your cardiologist for a non-STEMI cardiac arrest taken to the cath. Imagine my phone call to our cardiologist and said, I just put somebody on ECMO. Well, his response was, you did what? You did what? And so this really started something for us that has blossomed into something that's so much bigger. So Ralph Berry walked out of the hospital neurologically intact 9 days later after getting his LAD lesion capped. And since then, we've used him all over the place. Our initial data was amazingly good. 5 out of our first 9 patients walked out of the hospital neurologically intact. We did some interim data runs on this, and we found that in a highly biased population, that you were nearly 10 times more likely to survive if you got ECMO and RED than if you did not. Our most recent data has shown that a lot of the concerns about this just aren't true. We do about 1 case every other month, okay? Our hospitalization time on non-survivors is 2.9 days on average. These are infrequent events which don't take a whole lot of hospital time. And of the patients who survive for more than 1 day, so we get them through that initial phase, they get to the ICU, of those patients, almost 2/3 of them, 65% of them, leave the hospital neurologically intact. Those are our numbers as of right now. Well, we have a little delay. So today we're going to talk through three of the basic things. I'm going to tell you a little bit about the outcomes. We're going to talk about how this, who's doing this in the world and how they're doing it. And then finally we're going to get to some of these advanced procedures and some of the future beyond even ECMO. All right, so data in 2018. It includes, are we good now? Okay. 2018, we'll run through a little bit just so we're all up to speed on what goes on. ECMO is placing venous catheters, femoral artery catheters. One in the vein goes all the way up into the right atrium. We suck blood out of the right atrium. We pull it into a pump. We oxygenate it, and we push it back retrograde up the aorta to perfuse the coronaries and the carotids. That's the basic gist. Now, once you get past this, the physiology of ECMO becomes very fascinating. So that area right around the heart, that area that's so important where the coronaries and the carotids is the point of most interest to us in our post-arrest patients. Now, this is great when they don't have a heartbeat, right? When they're in a cardiac arrest, I can determine their PaO2 of their coronaries and their carotids by whatever I set that machine at. Problem is, we don't like people to not have a heart rate. And so once they get a heartbeat back, they now have perfusion of their lungs, which just got chest compressions for an hour, and the PaO2 of that is very different. And so you get this area, this confluence, this idea of differential hypoxemia, where the oxygen saturations of the legs are different than the oxygen saturations of the coronaries, and this allows us to have a physiology that we can make some adjustments on. One of the things that we can do right now is we can do what's called VVA. So classically in ECPR, we use VA ECMO, veno-arterial ECMO. But in these patients where we have differential hypoxemia, where the oxygen saturations are not great in the coronaries, we can actually add things. We can add cannulas in various places. One of the things we can do is even add a second cannula to the internal jugular vein and put it on the oxygenated side. Does that make sense? So now I have oxygenated blood that is going through the right atrium and thus alleviating the problem of having differential hypoxemia. I say that only to say that this gets complex. And there's a lot of things that, and we started ECMO, we didn't know any of this. And patients still ended up surviving. But the physiology is fascinating. Okay, so that's how it works. Now the question is, does it work? And in the last couple of years, we've had a number of case series that have come out with very exciting results. Probably the most exciting one is out of Minnesota. Dimitri Yiannopoulos and Jason Bardos up there have done amazing work. They are cardiologists who are taking out-of-hospital cardiac arrests directly to the cath lab and putting them on ECMO. They have an average time to initiation from the time that that patient hits their cath lab table to when they are on ECMO, 6 minutes. 6 minutes. All right? They're not getting these patients until they're almost 60 minutes into their code. So we're talking about patients that have had a downtime of 66 minutes, and their first paper they published 50% survival. They're now at, I think, 130-something odd patients with a survival to discharge neurologically intact of 42%. This is incredible results. Now, this is in a VF subpopulation, which you need to consider. They do a couple of other things that are interesting we'll talk about in a second. But this program has shown that if you do ECMO well, the survival is very good. We have no double-blind placebo-controlled trials in this, but probably the biggest comparative trial, it came out of Japan, which is called the SAVE-J. They did bundle therapies. They said, okay, we're going to send some cardiac arrest to the ECMO centers, some to the non-ECMO centers. And it turned out that the cardiac arrest that went to the ECMO centers did over 4 times better in survival. Over 4 times better. Our registry shows 28% survival for ECLS or for ECPR cases, patients that are in cardiac arrest. But with all these numbers, we need to think, what is the denominator? What is the expected survival of someone that's in cardiac arrest? Because we could say, okay, 60 minutes, that sounds like eternity. We would never even run a resuscitation for 60 minutes. But the thing is, we are taking the very best of those patients. We're taking the witness, the younger patient, the bystander CPR, VF sometimes, right? These types of patients. So what is the survival of those? And in the last 2 years, Josh Reynolds and Brian Grunow have done great work to tell us what we already know, but to basically tell the world what we already know. And that is, they're still dead. At 60 minutes, they're still dead. I don't care what kind of sub-cohort you take, they're still dead. Their survival drops off. You see there at 30 minutes, the percentages are around 3% survival. When we get 28% survival, our hospital is at 27% right now. Paris is at 29%. These numbers are quite high, quite high. All right, so who's doing this? Around the world, the cases every year are increasing exponentially. We published this paper a couple years ago, which with Utah showed that there were 26 different ERs in the US that were doing this. The numbers are far greater than that, far greater than that. At our Reanimate conference that Mike's talked about, we've trained 200 docs over 6 continents, and each one of those is the maven. They're the maven that goes back and starts their program and educates their class, educates their doctors. So these programs are turning up all over the place. Now, how this is being done is obviously not all with emergency physicians. Our hospital is definitely unique. We run this from the beginning to the end. We place the cannulas, we initiate the pump, we educate our docs, we even put in a number of the post-arrest management. We do a lot of that upstairs in the ICU. We've also, because we've gotten so good at this, we've now become the hospital ECMO team. So when a cardiac arrest is called to the ICU or to the trauma bay, they call us. They call us to go put in the cannulas, the emergency physicians. All right, inclusion criteria. This is kind of, it's something that we've gone back and forth on during the years. I like to say it like this. The ECMO is for the cardiac arrest patient who is neurologically and cardiovascularly salvageable, right? It just kind of encompasses what we're thinking, because there's so many nuances to cardiac arrest. There's so many nuances to each patient. You have imperfect information when you get. And so we have gone back and forth with strict inclusion criteria, but currently we get this basic understanding, but also understand what are the factors that are prognostically important. And these factors, what we say right now, are witnessed, bystander CPR with less than 10 minutes of no flow, time to initiation of less than 75 minutes. Does that sound like eternity to most people in this room? 75 minutes, and this is what the data is predicting, 75 minutes. The ECMO really makes you revisit a lot of things that you held true. The things that you held true, that people had to die at 30 minutes, that your heart was not salvageable after 10 minutes of no flow. These sort of things, we are now learning more and more as our numbers increase, that some of these assumptions we have are just not true. Last thing is, obviously, do not resuscitate, no terminal conditions. These are sort of the big 4 that we use. We used to use age. Our story about age went like this. We had our cutoff at 70, and the advocate, our CT surgeon, who has been such a great help for us during the years, was 73. And he found out about our inclusion criteria and said, hey, why don't you change that to 75, okay? So we have gone back and forth. The literature has shown that the age is not terribly important. Of all these factors, the age has not been important as far as predicting whether they survive or not. VFVT, we know VFVT has a better prognosis than otherwise. However, a number of our patients at our institution are PEAs. They're PEAs caused by PEs. And so, like I said, we are revisiting a lot of these assumptions. And even right now, we're revisiting the idea of asystole. Just like a month ago, I had asystole in the field. Would have been pronounced, brought to our hospital, put on a monitor. The monitor was read as asystole. Put an echo on the heart, not asystole. There was some cardiac motion there. Potassium, 9.8. 9.8, right? We put this patient on the pump before we even had their iStat, which is kind of also something that we have gotten so much faster at putting these people on the pump that we can get them going in not 6 minutes on average, but we've definitely had insertion times down in the single digits and some as low as 6 minutes. So these are things that take time. They take practice, but they can improve. And so revisiting what we take as assumptions, whether asystole is just a death sentence, maybe not so much. More data is definitely needed for this. Witness bystander CPR, these are one of the things that the Minnesota group says it's too hard to figure that out. How many of you have ever had a medic come in, tell you one thing, the family arrives and they tell you the exact opposite thing, right? That's pretty much par for the course. And so in our institution, we still make a big deal of trying to figure out, okay, is this patient witnessed? Did they have bystander CPR? Dimitri says, forget it. I'm not worrying about that. If they're in VFVT, I know that their heart is still salvageable. They are a recent arrest. I'm going to use that as my surrogate. Signs of life, this is pretty cool. This is what Paris does, and a lot of the world has actually adopted this as a result of what Paris did. They say, if you show signs of life during your cardiac arrest, your brain works, and we are going to trump you in. Doesn't matter what exclusion criteria you have, you get trumped in. So what would signs of life be? Well, we all have seen the patient where they're grabbing the ET tube as you're doing chest compressions on them, right? That patient is clearly a trump in. They, though, go as far as saying even pupillary constriction during cardiac arrest is enough to trump them into inclusion criteria. Interesting things. All right, so when to transport, this is revisiting, like I said, a lot of the assumptions we have. Currently, the mantra is stay and play, right? EMS, stay and play. Do not bring them to the hospital. Why? They're getting poor chest compressions in the back of a rig, and there's nothing in the ER that we can do that you can't do in the field. That's the mantra that we've been telling medics for the last 10 years, and I think is a good mantra. That is an appropriate mantra. However, now in light of ECMO, when do you transport? And Brian Grunow has been doing some work on this. The numbers are not clear. It's definitely different for PEA versus VFVT of when the ideal transport time is, but it's probably on average somewhere around 16 minutes. You give them a chance. The best life-saving intervention for cardiac arrest is electricity. Electricity. The VF patient, recent down, shock them, get them out, right? That's what you want to make sure that you get enough of that going on your VFVT patients before you transport them. On PEA and asystole, the number's probably a lot sooner, meaning that transport should occur earlier if you are going to consider ECMO on them. All right, so that is, we talked about kind of some of the numbers, how you do it. Now I want to talk about how you can do this in your hospital. How do I start? And I think the one word, if I were to sum up how to start an ECMO program, is with relationships. Relationships. Part of the reason that our hospital was successful at this is because we are a small community hospital. We all know each other. We don't have a lot of people. Like, we hang out with the CT surgeons on the weekends. We go surfing together. We go mountain biking together. These are interactions that are so important. They are so important to keep these programs together because you're going to have ups where you get Ralph Berry, who survives a miraculous save, and you're going to have downturns. You're going to have places where you did 3 in a row, and everybody says, why are we wasting resources on these cardiac arrests? So it's so important to develop relationships with your cardiologist, your ICU docs, your interventional radiologist in our facility, because that's who does our distal perfusion catheter. After you get put on ECMO, you have now perfusion going retrograde up your aorta. You need to get a catheter down that leg to perfuse the leg, not emergently, but within the first few hours. So all these physicians need to be involved, and of course the nurses that are taking care of them as well. So that's job number 1. Job number 2 is with admin. And admin it's something that we need to realize that they don't speak our language. Okay? We've heard people say that admin has come to them and say, there is a procedure that you do in your ER that causes a 70% mortality. It's called ECMO. And we want to talk about this, right? So we have to understand that they don't understand the same things that we understand. And it's our job to educate them. It's our job to make them understand that this is potentially going to fill up their ICUs, but in our experience, that has not been the case. These are for only select patients. The other thing that occurs, and I think Amal mentioned this a little bit in his last talk, is the idea of cath lab mortality cannot be understated. Some of these metrics that are on different specialties in the hospital have big impacts on your ability to have an ECMO program. So you need to address those with admin. You need to address that you will be working on those, or at least come up with solutions for how you can circumvent this. All right, the last one in here is to create your mavens. That might be you. That might be someone else in your department. But you need a few people that can be sort of the glue to your program. The people who are going to understand the nuances, understand where the problems are, spend the extra time to go up and figure out why the last episode or the last cardiac arrest didn't work well, or why the machine didn't work well, or what the downfall was. So these are the people that you need to sort of get on board early when starting your program. Cost benefit, this is the one that comes up a lot. What are the costs and benefits? For us, we actually do this quite cheap. Our circuit runs us about the same amount as a Swan-Ganz catheter. There are ways to do it much more expensive. Some of the latest devices are really fancy. The McKay CardioHelp is portable. There's ones that you can have air-driven pumps. There's ones that are rapidly primable. There are devices out there that are very slick. But in general, there are ways to do it without spending $10,000 a circuit, for example. The other one is cost of running the program. If you have CT surgery at your hospital, most of these costs are already there. They're sunk costs. These are not additional costs to us in the emergency department. Our use of the device is so small that you may realize that this is actually negligible for you. And then the last thing is cost of hospital stay. These are things where it's nice to know what your numbers are. It's nice to know so that when you're talking to admin and you know what your payer mix is. I mean, these, unfortunately, are some of the important questions that admin is going to ask you when you start developing an ECMO program. And then organ donation, this is one, if you listen to our podcast, we've done whole episodes on this, but there are programs in the world their whole ECMO program is funded by organ donation that results from these patients. You can look at this as an ethical problem, or you can look at this as an amazing way to gain more donors. Because patients that are on ECMO have great organs, right? Their organs are getting perfused artificially by a machine that's giving them great PaO2s. They don't have this downside of having to be hypoxic on a bunch of pressors for several days. Organ donation is one of the big deals worldwide as far as funding these programs. All right, so this is easy. Said nobody ever, right? This is not easy, but as you can see in our one institution, this has been very successful. The future is even cooler in my opinion. Right now, one of the decisions worldwide we're making is, where do we do this? Where do we do this? Do we do this in the ER? Do we do this with CT surgeons in the ER? Do we do this with emergency physicians in the ER? Or do we do this in the cath lab like they do it in Minnesota? Or do we do it like Paris? Does anyone know how Paris runs ECPR? In the field. I went out there and spent, Lionel and Alice, I'm very good friends with them. I went out there and spent several days with them. We did 3 ECMO cases in one day. Driving around Paris, one was in the middle of a freeway, one was on a basketball court. I mean, these are people that we could go out to the patient and place them on pump at the scene. Why is that? Well, it's the same reason. If you look at this, this is one of Lionel's pictures that I love. This is a picture that shows them pulling this patient out of the top of a building, right? That's how they're getting the patient out. And he has this is actually not the picture. There's another picture where he's looking from his ICU across the way, and you see them pulling the patient out. And the time from them to get from that place to his hospital is an hour. Same problem in New York City, right? Why is cardiac arrest survivorship in New York City poor? Because you can't get the patient there fast enough. And so certain cities, maybe pre-hospital ECMO makes sense. And I'm telling you, very shortly in the US, we are probably going to have a few cities that are up and running with pre-hospital ECPR programs. London just started this year with a pre-hospital ECPR on their air ambulance, which is also very cool. Here's a picture of us doing it out on the field. All right, so futures now. I want you to think about endovascular resuscitation. This is the concept. If we develop a skill set where we can be like the interventional radiologist, where we have those hands that can put in catheters and can manipulate catheters, we can do so many things. If you know anything about what I say, I love A-lines. I love A-lines for sick people. I love A-lines for sick trauma patients, cardiac patients, and arresting patients. I think they do wonderful things. But developing the skill set to put in an intra-arrest A-line is not easy. And it takes time. And it takes practice. And so, but once you get this skill, so many things are available to you. Reboa, we talk about Reboa often. Reboa is just a simple balloon occlusion catheter that's used for all kinds of things in IR. If you've heard about, SAP catheters or what Jim Manning is doing, where you can infuse substrate through the tips of these Reboa catheters and infuse things that could be blood or some oxygen carrying capacity. Or mentioning what Amal just talked about as far as epinephrine. We have all these trials showing that epinephrine in 1 milligram boluses is bad when it goes in the vein and sits in your vein until you get return of spontaneous circulation. What if you could use titrated small doses of epinephrine in the proximal aorta? Same effect on CPP, same effect on coronary perfusion pressure, and yet you don't have these deleterious effects to the brain that we see in a lot of the trials, like the one from Japan and the one from Scandinavia. So these are things that we can do with simple endovascular techniques. Other things that we've learned, I used to say, actually at our first 3 Reanimate conferences, I said, we're not going to talk about VV ECMO at all. It's not an emergency room procedure. And then May 2016 happened. We might have a little problem with that video. So Conrad Soriano, he is a young guy, anaphylaxis to peanuts, came into our ER. He had a pH of 6.7. This is after intubation. pH 6.7, PCO2 was in the 140s. We were doing the classic, sit on their chest to try and get him to exhale. Couldn't get him to exhale, breast stacking. And what did we do? We stuck a simple catheter into his neck. We pulled off the CO2. We gave him oxygen. And Conrad was fine within a couple hours. Literally fine. The guy was about to die, walks out of the hospital neurologically intact. This opens the realm to so many other things. What if we could have our failed intubation be a catheter rather than a crike? Right? Because we know what is the worst patient to have? Is the asthmatic. The asthmatic that you can't ventilate, you can't oxygenate. The ET tube does nothing, right? We're not even close to the problem. The problem is down in the bronchi. If you can just put a catheter in their neck, take off the CO2, oxygenate them, it's a simple fix. You could do this also for COPDers where they could be sitting up in bed and get their CO2 scrubbed. I make it sound very easy. It's not that easy. Okay? The current technology is not that easy. And in fact, there's a lot of risks associated with this as far as perforation of the IVC, as far as sometimes needing fluoro. Classically, we would use fluoro for this. And so these are the types of things that future technologies could be easily adapted to improve this in our ERs. Air-driven ECMO devices, where we could just use it with a simple pneumatic pump or pneumatic oxygen tank. This is already out there, being deployed right now in Europe, and hopefully will come to us soon. And then probably the biggest thing with ECMO is right at this institution, emergency preservation resuscitation, Sam Tischerman's child for the last 20 years, where Sam put dogs down to deep hypothermia, not therapeutic hypothermia like Amal's talking about, deep hypothermia, 10 degrees Celsius, 15 degrees Celsius. And he has now, through great work, gotten the IRB approval to do that in Baltimore, where he would take traumatic arrests, exsanguinate them, instill freezing cold saline via ECMO catheters, and then take them to the operating room and repair their lesion. Suspended animation going on right now in Baltimore as we speak. So the future is big. I want you to understand that our ability to do these procedures can lead to great improvements in care. It can also lead to innovations that we haven't even thought about. And so when we start thinking about things that we could do, taking all these procedures that we know are advantageous to our patients in a timely fashion, even things like angiography could be potentially in our scope. All right, final things. ECMO. Data is not definite, but it is compelling. 28% survival versus 0% survival. Starting a program, key is relationships, and then the final thing is that the future of resuscitation is dependent on our ability to develop a new procedural skill set. Thank you.
Thanks so much, Zach. And I can say here